Hello, welcome to Complete Physio podcast. We're here with Serge Nikolic, and we're going to be talking all about sciatica. So, Serge, introduce yourself.
Thank you, Chris. So I'm a consultant in spinal pain medicine and neuromodulation, and I've been doing this for many, many years. Majority of my patients, spinal pain patients. I work on the NHS and I work also privately, and we've known each other for quite a few years now, haven't
15, 16 years, Serge?
and a half, yes, indeed.
And more recently, I had sciatica. So this is one of the reasons we wanted to do the podcast, because I came to you because I had leg pain, and we'll talk about what sciatica is. And actually things weren't improving, so I had some injections done, which made a huge difference. But what we want to do today is to get across, what is sciatica? What should you do about it? When should you seek help? Etc., etc. So I think sciatica is one of the terms that gets thrown around by a layman. It gets, you get diagnosed as sciatica, but what is sciatica?
Well, sciatica is essentially a symptom. Sciatica is a Latin way of saying I have pain in the distribution of sciatic nerve, which complicates it, I know.
Yeah.
But what that means is I've got pain in the leg.
Yeah.
And not all pain in the leg would be labeled sciatica, if you like. And we're talking particularly pain at the back of the leg, start in the dip in your buttock.
So it starts in the glutes and goes all the way down the back of the leg.
It goes all the way down, and particularly goes down below the knee level. And tends to affect, if you like, the outer aspect of your leg and the back of your leg, your hamstrings. And then when it gets below the knee, it affects any part of the leg. Often is associated with pins and needles, degree of numbness, funny tingling sensation in the same area, and every now and then can be associated with a degree of motor weakness.
So weakness in the muscles.
Weakness in the muscles. So you struggle to walk, you can't quite lift your leg, the pain is excruciating. It's often very, very, very sharp. Very sharp, electric shock-like. It's deeply, deeply unpleasant. But, and this is a difficult concept for people to comprehend and understand, because the pain is predominantly in the leg. They feel, well, Christ, something's wrong with my leg. Whereas this is not the case. There's nothing wrong with one's leg. Sciatica, when it comes to causes, there are many causes. By far, the commonest cause is actually what generally people know as a slip disc. So
what do you mean by that?
Indeed,
because for me, anybody would, this is the spine here. That implies that this disc has slipped out. Surely that doesn't happen.
In a nutshell, let me just, few things about spine, which, Chris, I'm sure you'll find very educational at this point. This is somebody's lower back. This is somebody's spine. Spine is essentially from here to there. It's got bones called vertebrae. They're stacked on top of each other. But these vertebrae connected amongst themselves by three means. There are discs in between them, these yellow bits. There are small joints at each segment in pairs, one left, one right. You can't see them like that, but you can see them like this.
So facet joints.
These facet joints, indeed. And these are the small joints in pairs on each side. And then there are ligaments and muscles that keep everything in place. Now, every single vertebra would have a body, and there is a hole there, as you can see. And there are these bony bits at the back that one feels when you feel your spine. You can feel this knobbly bit at the back. Now, these holes are aligned and creating a canal, if you can see, through which this is, as you can see, quite worn off, a canal through which these things traverse. So the spinal cord itself, in fact, ends in your upper back. But the nerves that emerge from it continue to travel down the canal and exit the canal in pairs, one left, one right at each segment.
So you can see those things.
You can see them there. Now, these nerves then would merge and combine to form other nerves. So typically, if we're talking about sciatica, which we are, the sciatic nerve is actually formed out of these nerve roots, two lowermost nerve roots, to an extent a little bit out of that, but mainly these two. But also these other lower nerve roots that are in the tailbone, in the sacrum.
So the nerves come out and then they go into the leg and they combine to form the sciatic nerve.
Just a few things about sciatic nerve. Let me tell you. First time I saw sciatic nerve in real life It's actually shocking how massive that nerve is. It's the size of my little finger.
Yeah, 1 centimeter, they say, don't they?
It's absolutely the largest, it's massive, largest, and probably the longest nerve.
Yeah.
It comes from your back, winds through your buttocks, if you like, through your pelvis, go down the leg, and at the knee level, roughly splits into its terminal branches, and it goes down to supply all the rest of the leg, if you like. So, now, all of the nerves that come from the spine, I don't know if you can see, but they've got this little knobbly bit there, which we call the root of the nerve. Now, this root of the nerve is very closely positioned to the disc. Now, I will stop at this juncture just to tell you a couple of things. Spine is designed to handle the load imposed on it in such a way that 80% is handled by the discs, 20% by the joints. As one ages and through abuse, if you like, excessive manual work, sport, what have you, or we don't know why, the discs become worn. The body is designed to compensate for this. And that's why there are many, many asymptomatic people out there who would have a worn disc, who have a degree of disc bulge and whatever, but with minimal symptoms. But there comes a critical point when this disc essentially starts to bulge. Now, the disc is sort of a lens-type structure, looks a bit like a donut, but it's got a very firm ring on the outside and soft bit in the middle.
I like to describe it like a locket.
You can.
So you've got the hard shell. It's not a shell, but the hard bit on the outside, and the inside is more fluidy.
The locket, you would describe it because you're just as romantic in a loving relationship. I understand that. So what I'm saying is that this disc becomes worn and it starts to bulge. And this soft thing in the middle and the substances in there are actually quite irritant, and they're meant to be in it.
Yeah.
But through wear and tear and small cracks, they tend to leak out, and the nerves are very sensitive to that.
Sure. Hence you get the inflammation of the nerve.
Hence you get the inflammation and irritation of the nerve. So the nerves get irritated at this level, if you like, but because these nerves convey information to the brain from your leg, your brain and spine thinks that something's wrong with the leg.
Yeah.
Whereas in fact the issue is here. But as I've said, the vast majority, or in vast majority of cases, if you like, the disc actually bulges a little bit more, enough to actually physically squash the nerve to various degrees, if you like. Usually, if we have a motor weakness, if the muscles are not quite behaving, you can't quite walk, that means that a compression, usually it means that a compression is quite significant, because the nerves that control the muscles are actually very deep within the whole overall nerve.
So for example, if your foot, something we call a foot drop, if you've got weakness, you're tripping up a curb, and you've got weakness for the muscle, then normally it indicates that it's hitting the center of the nerve.
The likelihood is that we are not talking
or
just a little bit of something, irritation, if you like. The likelihood is that the disc material, if you like, or the disc protruding, if you like, out of its place where it should be, is more significant, and that compression to the nerve is more significant. And therefore, when we talk about motor nerve compression, or nerves that supply the muscle compression issue, we ought to be really a little bit more proactive about it, because the pins and needles, the pain in vast majority of cases tends to recover relatively quickly in majority. But when it comes to motor power and etc., that's an entirely different ball game.
And if you continue to have weakness and the nerve is being compressed, then actually, if you don't action that sooner rather than later, you can end up with some long-term weakness.
If you don't act upon it, the likelihood is this recovery from the motor control, if you like, tends to be far less than what we would actually want it to be.
So to conclude so far, we've got pain down our leg, and a majority of the time that is due to a disc problem in the back, even if you don't have actual low back pain.
Indeed. It can be present in the absence of the back pain. Degree of back stiffness.
But you can have it too,
yes,
can't you?
The degree of back stiffness is inevitable.
Yeah.
Degree of muscle spasm is inevitable, because the spine senses this and tells these muscles to go into spasm.
Yeah.
And the reason the spine does that is wants to stop you from moving, because further movement will irritate the nerves more, and the spine tries desperately to contain this.
Sure.
But the important thing is that in majority of these cases, to start with, sciatica is exceedingly common. It happens in young people. It happens in teenagers. in teenagers. Not that I would remember those years, but Chris, you're unlikely to remember either. But it can happen in teenagers. It's not uncommon.
Yeah.
It's less likely, interestingly, to happen at the advanced age, if you like, because it's all settled down. The discs are whatever they are. The new kind of type.
Well, as you get
slim.
older, the discs they don't, that softness in the it gets less soft.
They get worn, if you like, and get into what we call a steady state, if you like. So that's the commonest cause for this label sciatica that so many people get. Usually, the treatment pathways is very, very, very straightforward. And it's in my line of work, if you like, to see a patient who had sort of semi-acute, if you like, sciatica. It's just a breath of fresh air because the treatment pathway is relatively straightforward. If it's new, then really they ought to get a bit of rest, anti-inflammatory, paracetamol, what have you.
So, Serge, if somebody was sitting at home, they've just got onto YouTube, they're in agony, and when we say agony, nerve pain, which is what we're talking about, is some of the worst pain you can experience, isn't it?
People climb up the walls with it.
And if you're not doing that, then it's either very mild or it's something else. So they've got raging leg pain down the back of the leg. They've just woken up. Sometimes it could be following a fall, but most of the time, let's be honest, you hit that threshold and it becomes painful. What would you advise at that point they should do? Panic is probably the first one.
To start with, not panic.
Because it's very common.
But it's easier said than done.
Yeah.
Let me tell you, the true proper sciatica, you climb the wall with it. So even if you warn them, even if you tell them, off you go and see your physio and do 10 squats, whatever, they won't be able to do it. So one really ought to follow one's common sense. In these acute situations, provided they don't have a motor power loss, if you like, they can't move their legs or what have you, they ought to rest. And they ought to rest. They get your box standard over-the-counter painkillers, anti-inflammatories, etc., if they can tolerate them. And usually what people find helpful is when they rest with the leg slightly flexed in the hip. Because sciatic nerve is so long, any other position tends to stretch the nerve, as normally it's a dynamic situation, if you like. But because the nerve is so irritated, any further dynamic stretches that normally we would not know about because the body is designed to absorb it, it becomes even more painful. So it tends to be with the leg stretch or pillows resting under the leg, etc., etc. Now, as I've said, in majority of cases, that's sufficient, and usually within a couple of days, few days, tends to ease off a bit. And if it does, great. I certainly would not go wild if the pain drops down by, say, 50%, but not completely. And then, Christ, I'm going to go now and start running to Hastings. No, one needs to be kind of very careful. But if the pain does drop, then would be the time. It's not unreasonable at all. In fact, it's advisable to seek some professional help initially from a senior physiotherapy group, if you like, who will then educate them exactly how to go about these stretches and gentle exercise, provided these exercises don't make it worse.
I'm just going to pick up on a few things there, Serge. So talking about painkillers and anti-inflammatories, a lot of patients go, well, I don't want to take that because, I'm going to numb it or I'm going to do myself more damage.
I'm so glad you manage this. I hear this all the time. They come here and they can hardly sit in the chair. And I was like, well, what do you take? Well, nothing. Why not? Well, I don't want to mask it. I said, well, what do you mean by that? I'm not asking you to load yourself with morphine so you're as high as kite. But why? And I said, because there is this conception out there that if you take your painkillers and mask it, then you cause further damage. Let me tell you one thing. In true sciatica, I can tell you now, a couple of paracetamols and a couple of Nurofen are not going to mask it enough for you to damage, cause further damage. Further damage is very unlikely. I think
that's a really important message.
And in fact, it's an important message because you ought to be comfortable because this severe pain causes all sorts of compensatory kind of activities arranged by the spine. If you like, everything goes into spasm. The body tries to readjust itself. I think at this stage, common painkillers over the counter are entirely appropriate. I'm not certainly advocating
take it regular. I see some people where they take one and they go, well, it didn't work, so I didn't bother. But you do need to take these
you do need to take them for some period of time. I'm not suggesting for all eternity, far from it. I'm not advocating
5 days
but
to see if it helps.
In this acute state, yes. I mean, admittedly, if you don't kind of notice any benefit after a few days, then really that's not going to be the answer. We need to either kind of change the medications or do any intervention of some sort that will radically improve this inflammatory acute changes and hopefully push you into kind of healing process, if you like.
And so as a physio, if somebody comes in with acute pain, the general advice, as you say, is keep the knees bent. The classic thing is people think they should try and elevate their foot because they've got leg pain.
Well, in fact, that makes it worse.
That makes it worse. Hamstring stretches. So anything that's going to stretch the nerve will aggravate it. Even if you don't feel it at the time, you will aggravate it after.
Well,
just a couple more things. Initially, if you've just woken up with pain, and you start walking around and it starts to feel a little bit easier, that's great. But don't be afraid to take it very easy for that first day or two. But then the evidence will say, won't it, is that we want to get things moving as we can. And then my last point is don't get this blimmin' Theragun out and start gunning down your whole leg. I can see our cameraman nodding, thinking, oh, I'd do that. But, so all you're doing by smashing this thing down your leg is smashing the nerve, which is already irritable.
I see this all the time. Yeah. People have all sorts of misconceptions. And the common thing is, we all like that these days. I mean, I'm not particularly IT savvy. I wish I could be, but I'm not. But I mean, we all need, you have something wrong with you and you Google it. And then these days,
you get something off Amazon.
But the problem with that is that people who suffer from pain, by definition, are vulnerable. People who are vulnerable, by definition, are prone to exploitations. One needs to admit, no matter how cynical or not cynical one is, that the majority of the internet content is designed to exploit. And I say this not in particular cynical ways, the truth. I'm not talking about any illegal content. I'm talking about bog standard stuff and not in any nasty way or whatever. But it is the fact. There are all sorts of treatments that are available. You go to Holland and Barrett.
If you Google sciatica, I'm sure it won't be long before a Theragun advert comes up, for example.
You go to Holland and Barrett equally. You start from the left shelf, you go to the right shelf. Every single box promises you the Holy Grail. Which is not quite like that. This type of treatment for acute stages of sciatica, as far as I'm concerned, is inappropriate. However, people do all sorts of things. My late mother-in-law swore by this electric, some pen, whatever, that apparently kind of magically helped her knee that needed replacing. And we are not like
we're always going to get those stories, aren't we?
But in principle, I think common sense is the best approach.
Good. So what will happen is the patient that's sitting there at the moment, they'll take that advice on board, hopefully. I think we know that a majority of these problems, a majority of them will go in the first week because we never see them. But it's not uncommon for sciatica or an irritation of the sciatic nerve to take around 4 to 6 weeks to totally go. Would you agree? And at that point, probably there's only 10 to 20% of those people left.
Normally, when you talk about percentages, I'm not quoting this any hard evidence out there, but in principle, 80% of patients that have it will sort itself out within a week or so. 2 weeks. Out of the remaining 20%, 80% will improve with some rehab type thing that you magically render. And only small proportion will require further treatment. Where is that cutoff point in the time scale? We are talking in the absence of muscle power issues. That's a different story. We are talking about raging sort pain,
bog standard,
standard, but muscle control is fine. Where is the point at which we offer something more?
When should you get an MRI surge? That's the question people ask.
If you get stuck, if they get stuck with you, with a good physiotherapy after a few sessions, or they can't tolerate it, it's way too painful, I think it's entirely clinically appropriate. And in this kind of case, if you like, to arrange an MRI scan is equally within guidelines. So as we know, MRI scan is a non-invasive intervention. Some people will have an issue with claustrophobia, whatever, but we can cater for these patients. There are ways of circumventing, if you like, this. But MRI scan is important.
And that will give you the diagnosis in a majority
in vast majority of cases, as I've said, because in vast majority of cases, the cause is the disc. We need to know the level, because although we know this clinically, more or less, but equally, every now and then there are surprises.
And when you say the level, what you mean is the level of the disc
by far
prolapse.
The commonest is L5S1. Which is this lowermost one. Because it's a commonest part, all of you this is the part that takes the highest toll, if you like. So this disc tends to wear quickest, then the L45 is next one after that. at these two levels, the disc tends to kind of bulge. So will it bulge to the side? Sometimes it bulge inside, and there are different kind of symptoms associated with it, but also different types of treatment one would consider. But one way or another, if for nothing else, for reassurance sake, it is really, and most patients would want that. Most people would want to know after their time.
They'd want to know what's going on and therefore what are their options. And certainly from a physio point of view, when you've got that real acute sciatica, you can be quite limited with what you can offer.
Certainly.
When it starts to get a bit better, I think that's when physiotherapy, and by that I mean manipulation, mobilization, soft tissue treatments, acupuncture, exercise-based treatments, I think that will then get another certain percentage of people better. And then I suppose the patients that you see are the ones that aren't getting better and are considering other options.
Yeah, the patients I see are the ones that struggle to improve with your good work.
Yeah.
Or the patients, there is a group of patients that actually can't quite do, they seem to get a little bit better. Then you try to embrace this kind of conservative approach, if you like. But that pushes them backwards, makes it worse, and the cycle repeats.
Yeah.
At that point, it is, once we've seen the scan, it's entirely appropriate, completely, totally appropriate, and still within all guidelines, is to consider an injection.
And so what do you, if somebody's, got sciatica and they're 3 months, 4 months down the line, I don't know if they can't work or they can't walk or they can't do what they love doing, what do you mean? Give me a bit more detail about what do you mean by a spinal injection? How do you do it? What do you inject and why?
Well, these injections are done in theatre as a day cases, albeit in and out.
Yeah.
The procedure itself is very quick.
You did it to me. I think I was in and out in the theatre. I was in and out for 20 minutes, and it's done in theatre not because you're having a general anaesthetic.
It's done in theatre for two reasons.
Yeah.
Or one main reason and one additional reason. The main reason is I need extra vision in real time.
And what do you mean by that?
When people come in, usually I would put a little needle in the vein on the back of your hand. A patient lies on the tummy onto the operating table. There is an X-ray machine around them, which is not a tunnel type MRI machine. It's
like
just
a big light when you go to the dentist, isn't it? Yeah.
So there is an X-ray machine around there. I've got a big screen in front of me, and I see the spine, and more importantly, my needles on the screen in real time.
I hope it's HD.
And that guides me as to where to place the needle. And the needle, say we are talking about your case, we're talking about L5S1, if you like,
which is a very common.
We're talking about, if you like, right leg pain, right-sided sciatica. So when the patient lies down like this, or left-sided because it's easier to see, the needle will come to rest in this little gutter there. And I see that on the screen. So the needle does not go into the spine.
No.
It does not go into the discs or the nerves. It just rests there. So when I give the drug, which is a small amount of steroid, that flows into this hole there to bathe the disc and the nerves. And
so you're injecting steroid around, not into it, you're injecting around the area, you're bathing it. And what does that steroid do?
Yes.
Hopefully.
So the needle certainly does not go into the nerve. No. Nor will you let me, even if I wanted to. No. So then doesn't go into the nerve, doesn't go into the disc. But the steroid comes to where the nerve and the discs are. And the steroid is then kind of, if you like, floods this area. And steroid is the one that powerfully in a targeted fashion, specific fashion, reduces inflammation, swelling of the disc. In some cases, it does reduce the disc bulge size, if you like. And it reduces swelling around the nerve, irritation in the nerve, and breaks the pain cycle. And this is what tends to happen in carefully selected patients. It tends to happen in majority, if not the vast majority of cases. Now, the second reason they're in theatre, because some people are kind of understandably are not having a massage, they're worried, a needle, spine, it's all big thing. Understandably so. So the second reason is once I've obtained the images, once I've marked the skin, etc., through the cannula, I would normally give them a little bit of something so that it doesn't hurt.
So sedation.
And most patients have a little snooze and minimal, if any, recall.
But it's not a general anesthetic.
It's not a general anesthetic, certainly. There is no need for general anesthetic. And yet, after all these years, I'm yet to stop the procedure because patient and I are about to fall out.
Yeah.
So it's not a big. And in
Well,
fact,
I can
and
say
in
I've
fact,
had
you
it done,
none.
Serge. I had no sedation, and I was shocked how little I
but you're a
felt.
minority, Chris. So we all know how.
Very
how
brave. You're
you are
correct.
sort of what's the name of the guy?
Who's that?
Grills, Bear Grylls, and
just
then
like
you.
him.
Yeah, just SAS.
I actually
kind of
hate camping, but anyway.
Yeah. Well, anyway. So the steroid is the active ingredient.
Yeah.
The steroid is usually mixed with a very small amount of local anesthetic.
Yeah.
None of them are painkillers.
No.
Which is important to understand. It should be a key home, if you like, message.
Yeah.
None of them are painkillers. They help pain, improve pain by reducing these pathophysiological, if you like, processes by reducing swelling, inflammation, and breaking the pain cycle.
An anti-inflammatory, but very targeted,
targeted, and very strong. But it may not work on day one.
No, sure.
It can take a couple of weeks. It can take variable period of time until the actions of steroid, if you like, are complete to result in pain improvement in majority of these patients.
Yeah.
Ultimately, these type of injections are quick and safe.
Yeah. Oh, without a doubt.
And they do achieve what they.
But you do need to see somebody that does a lot, has a lot of experience.
Indeed.
And the other thing that I found when I had my injections, I did get very, very quick relief. And that gave me a really good window of opportunity to then concentrate on my rehabilitation from a physiotherapy point of view.
That is the purpose of the injections. And I always say to my patients that they're really not magic. They can't turn a disc that's bulging and worn and whatever into a new plump disc. However, the purpose is, genuinely as what we've said, is to break this pain cycle, acutely reduce this inflammation and irritation, and in doing so will improve and facilitate your good work to optimize now and restore their mobility, to optimize the core, to optimize the muscles, do stretches, etc., and then educate them as to how to maintain them themselves. And this is what tends to happen in majority of cases. Only minority of these patients will they require something more invasive.
And obviously it helped me, but my experience of 20 plus years of seeing patients that have had these injections, it's definitely worth people considering, isn't it? If they've got a lot of leg pain and they've got a MRI that has confirmed a diagnosis. And I think we both agree we're never going to tell somebody they've got to have a spinal injection, but at least they should be provided with that as an option at the right stage, provided with the right information so they can make their own decision.
I mean, this is all about being proactive and taking control of one's life.
Yeah, absolutely.
People kind of feel that they're proactive by procrastinating. That's not uncommon.
No, sure.
So we need to kind of be proactive because the goal of that is to prevent disability and chronicity.
Yeah.
And
but at the same time, we're not saying everybody needs a spinal injection. A majority get better with good physio.
We started off with that. We are talking about whatever percentage of the initial cohort is left. Which is good. And this is by far the commonest cause. But I mean, every now and then we do have sciatica type symptoms that are not caused necessarily by a slip disc that squashes, if you like, the nerve, etc. Sometimes the compression can be in the buttock area, in the gluteal area, in the pelvis itself, something higher up, something.
Can even come from even higher up in the spine.
I agree. It can come particularly when the symptoms are unusual, when they're both legs, and that when the symptoms don't quite match what we see on the MRI scan findings. And sometimes, as we may well touch on sometimes we see sciatica type symptoms in piriformis syndrome.
Yeah, which actually I think we might leave it at that, Serge, because piriformis syndrome is definitely something that we believe gets overdiagnosed. Often it is just related to a disc problem, but I think we will do a separet podcast on that.
I think it's important because there's a lot of misinformation and misinformation about it, and I keep hearing my physiotherapy diagnosed me with piriformis syndrome. How about it?
Yeah, and it is very, very rare, to the point that maybe not even 1 in 100 patients with sciatica actually have piriformis syndrome.
I couldn't agree more. And certainly if you look at the MRI scan findings, only rarely would we see actual changes within the piriformis muscle sufficient enough to actually physically cause the irritation of the sciatic nerves that goes around it.
So if you have enjoyed this and you want to know a bit more about piriformis syndrome, so if you've been diagnosed with that and you want a bit more information, then we're going to also do a podcast with Serge on that. But Serge, thanks very much for joining us. Thank you for helping my sciatica. I do hope it doesn't come back.
I don't think it will. I mean, you're just a brave kind of guy. And thank you so much, Chris, for inviting me. It's been a sheer pleasure.
Thank you very much, Serge.
Thank you.